Hi everyone. So the disease we chose for our assignment is Waldenström's macroglobulinemia. So the rare indolent B-cell lymphoproliferative disease known as Waldenström's macroglobulinemia, which can be shortened as WM, is characterized by malignant lymphoplasmacytic cells producing excessive amounts of monoclonal immunoglobulin M, which is known as IgM. This subtype of non-Hodgkin lymphoma (NHL) is thought to share characteristics with the lymphoblastic lymphoma (LPL). The median age of diagnosis for Waldenstrom's macroglobulinemia is around 65, primarily affecting older people, means like those who are above age 65 and 70. And I'll pass it on to the next member.
So, hi everyone, I'm Srikanth PILLAI, son of SELVADURAI. So, I'll be talking about the sign and symptoms for this cancer. So, firstly, will be the major and circulation systems, which will be mainly shows that the sign and symptoms such as fatigue and weakness. The skin will be pale and it will be very difficult to breathe, and there will be frequent headache or dizziness, and our vision will be blurred or we can see double vision, and also our blood and also gums will start to bleed, and also there will be easy bruising on our body parts, and also there and lastly will be Raynaud's phenomena, which is the fingers will be turned into blue or white and gold. So next will be the effect on immune systems and also in organ. So the lymph nodes, spleen, and liver will be enlarged for this, and also there will be frequent infection occur, and cold agglutinin disease, which is known as cold sensitivity, and there will be the presence of rashes or itching over the skin. So lastly, we will be seeing combined general nerve and hidden signs such as peripheral neuropathy, which is numbness or tingling, and there will be confusion or memory loss for the patient. And during night, there will be night sweats, and also patient might overcome fever, bone pain, and also the weight will be lost drastically. So the weight loss can't be explained. So that's all for my part. Thank you.
Hello everyone, my name is Kishore, and I'll be presenting about the pathophysiology of Waldenstrom macroglobulinemia, which is also known as WM. So it starts with naive B cells developing through either spleen or lymph node pathways. These naive B cells enters the germinal center for further maturation. Within the germinal centers, B cells undergo several critical changes like somatic hypermutation, isotype switching, and affinity maturation. All of these changes leads to the formation of mutated single isotype CD20 plus memory B cells, which can be CD20 plus or CD28 plus. These memory B cells circulate through the body and can home back to the bone marrow. Some naive B cells may differentiate into two cells, which is CD27 minus naive B cells and CD27 plus marginal zone, which is MZ like B cells. These further develop into CD27 plus Waldenström's precursors. The Waldenström's precursor cells differentiate into lymphoplasmacytoid cells, which is also known as the WM cells. So, in the bone marrow, WM cells give rise to bone marrow blast cells. Several survival signals in the bone marrow niche support the persistence and proliferation of WM cells. Some of these signals are known as SCD27, which is also known as soluble CD27 cells, CD40L, and April cells. April cells is referred to as a proliferation inducing ligand. Thank you.
Macroglobulinemia is a rare indolent B-cell lymphoma characterized by the excessive production of monoclonal immunoglobulin M, which is IgM, by malignant lymphoplasmacytic cell. Its clinical course is typically slow, but the disease can present with wide range of symptoms and lab abnormalities, making it diagnosis and management both challenging. So now we observe the lab diagnosis. So the initial step in diagnosing WM involves a combination of clinical assessment and laboratory investigation. Patients often present with non-specific symptoms such as fatigue, weakness, and anemia, which are the result of bone marrow infiltration by malignant cell. Laboratory tests play a crucial role in confirming the diagnosis. A complete blood cell count, which is CBC, is performed to detect the anemia, thrombocytopenia, and leukopenia. Serum protein electrophoresis, which is SPET, is used to identify the presence of the monoclonal IgM spike, which is the hallmark of the disease. Immunofixation further characterizes the monoclonal protein, confirming it as IgM. So, quantitative immunoglobulin tests measure the level of IgM, IgG, and IgA, helping to assess the disease burden. In addition, a 24-hour urine protein electrophoresis may be conducted to check the presence of the Bence-Jones protein, which are the monoclonal light chains found in the urine of many patients with WM. Other than that, bone marrow biopsy is essential for the definitive diagnosis. The biopsy typically reveals the infiltration by lymphoplasmacytic cell with at least 10% clonal lymphoplasmacytic cell required to confirm the WM. Other than that, flow cytometry is used to identify the abnormal B-cell markers, and molecular testing for the MYD88 L265P mutation, which is present in over 90% of the cases, provide further diagnosis confirmation and guide therapy. Now we observe the screening test. So the routine screening for WM in the general population is not recommended due to its rarity and indolent nature. However, in individuals presenting with unexplained anemia, neuropathy, hyperviscosity symptom, or organomegaly, targeted laboratory screening is warranted. So this includes the CBC, SPEP, immunofixation, and quantitative immunoglobulin. If these tests suggest the presence of the monoclonal IgM, further diagnosis workup is initiated. Now for the advanced testing. So the advanced diagnostic techniques are employed to differentiate the WM from other lymphoproliferative disorders and to inform the prognosis and treatment. In addition to MYD88 mutation analysis, testing for CXCR4 mutation may be performed, as these mutations can influence treatment response. Imaging studies such as CT scan of the neck, chest, abdomen, and pelvis are used to assess the extent of lymphadenopathy and organ involvement. MRI of the brain may be indicated in cases with neurological symptoms to rule out the CNS, which is central nervous system involvement. Additional tests including the serum beta 2 microglobulin and lactase dehydrogenase level provide the prognosis information and are incorporated into risk stratification models. Now for the treatment management of WM is highly individualized based on the severity of the symptom, disease burden, and patient comorbidities. A symptomatic patient may be managed with watchful waiting, as immediate treatment is not always necessary and can be deferred until symptoms develop or disease progression is evident. For symptomatic patients, particularly those with hyperviscosity symptoms, plasmapheresis is used to rapidly reduce the IgM level and alleviate symptoms. Other than that, chemotherapy remains a mainstay of the treatment, with the agent of the bendamustine and chlorambucil, which is commonly used. Lastly, immunotherapy, particularly with rituximab, which is an CD20 monoclonal antibody is effective either alone or in combination with chemotherapy. So, recent advances have introduced the targeted therapies, most notably Bruton tyrosine kinase inhibitors such as ibrutinib, which is significantly improved outcomes for WM patients by significantly targeting the malignant B-cell signaling pathways. So, in selected cases, especially in younger or fit patients with relapsed or refractory disease, autologous stem cell transplantation may be considered. So, the supportive care, including transfusion and infection prophylaxis, play a vital role in maintaining the quality of life during treatment. In conclusion, Waldenström macroglobulinemia is a rare and complex hematologic malignancy that require a multidisciplinary approach for optimal diagnosis and management. Laboratory and molecular diagnosis are central to confirming the disease and guiding the therapy. Although WM remain incurable, advances in targeted therapies have improved survival and quality of life of many patients. The indolent nature of the disease also allow for careful monitoring in selected cases, while symptomatic patients definitely benefit the range of effective treatment options. Other than that, the research continues to refine our understanding of WM and promise further improvement in patient outcome in the future. That's all from me. I'm ROPANA BUMINAZAN. Thank you.